Now I invite Dr. Ikeda to speak on soft cataract, and she can continue with the next posterior cataract.
A very good morning to all of you. I will be talking about phacoemulsification in soft cataract. So soft cataract, two steps that we need to keep in mind. One is rhexis, as it tends to run away since these are younger patients with elastic capsule. And secondly, the difficulties during phacoemulsification. As the cataract is soft, we end up operating on slightly lower vacuums, and this helps us in causing us difficulty in achieving a good vacuum seal and therefore chopping, which leads to formation of a bowl, and we tend to operate more in the peripheral zone, which increases the risk of posterior capsular rupture. So here the forceps help us in completing our rhexis if we find that we are not getting enough control with the cystitome. Now let's talk about the nucleus removal. In harder cataracts, since we use higher vacuum and the nucleus density is more, we end up achieving a good hold. Whereas in softer cataracts, because of operating at lower vacuums and as well as the nucleus being soft, it causes difficulty, and the epinucleus in these soft cataracts tends to be very sticky, and this makes it difficult for us to pull the nucleus towards the center to chop safely in the central safe zone. And therefore the tendency towards operating in the peripheral unsafe zone, since we try to get out of the sticky situation and pull up the nucleus. Now let's look at a few cases. This first patient here is actually a patient who is undergoing refractive lens exchange. So there is no cataract, it's a very soft lens. So here we managed to complete the rhexis with the cystitome. We have a good sized rhexis, so the technique that we use here in very soft cataracts where the rhexis size is adequate, say at least 5.5 millimeters, is just with the hydrodissection cannula, push the fluid wave till the time one of the poles of the nucleus prolapses up. And this makes it very easy for us to just emulsify the whole nucleus, as it is very difficult to chop since the nucleus is very, very soft, extremely soft in these cases. Now, if we find it difficult to remove this sub-incisional epinucleus and nucleus, we can pause, inject viscoelastic or dispersive OVD underneath it, and this will help us in prolapsing this soft nucleus up, and we hardly use any phaco energy in these cases. It is mainly vacuum, therefore very less chance of toxicity to the corneal endothelium, and we can safely emulsify these nucleus in the anterior chamber. Now let's look at another technique here. Again, I have a decent sized rhexis. So what I'm going to do is I am prolapsing slightly one of the poles up, but this patient has a small central nucleus as well. So a good hydrodissection and then a good hydrodelineation, followed by removal of this anterior epinucleus which sticks to the nucleus, gives us access to this small endonucleus that we have, and then we have just used the chopper to nudge up this endonucleus up and then just emulsify it with ease. So this is another technique. We can use our chopper once we have removed the anterior epinucleus to access the whole nucleus and emulsify it. And then we are going ahead now with the removal of the epinucleus plate over here and proceeding in the standard fashion. Now, another technique to use in soft cataracts, especially if the density is not that less or if we don't have a very good size of rhexis, is stop and chop, which is my go-to technique, especially for soft cataracts. So here again, we are removing this anterior epinucleus using mainly vacuum and no phaco energy. Here, rotate and remove the anterior epinucleus so that we have access to the nucleus a little bit more. And then the trench that we need to make here is not very wide. We need to make a slightly shallower trench, that we will narrower trench and shallower trench than we would make in hard cataracts. And then we can easily crack this into two heminuclei and proceed safely with stop and chop. The settings again that we'll use here, we'll use a moderate amount of vacuum. Do not operate on very low vacuums because that will make the fallibility of the fragments very less. Moderate amount of vacuum and low power settings are enough to deal with these kind of cases. So here we are just rotating the heminucleus and chopping the second part of the heminucleus. So this is another technique we can use, especially we are dealing with grade 1 to 2 nuclei which are not very soft. Now, let's look at this case. Typically, the problem, difficulty that we face in these patients is we have a formation of a bowl. So this is what has happened here. I'm proceeding with stop and chop. I've managed to crack the nucleus to divide it into two heminuclei, and we have a good hydrodissection and a good hydrodelineation. But as soon as I try to grab this soft nucleus, it just cheese wires, and I'm unable to get a good hold of the nucleus. So what we need to do when we are stuck in a situation like this, keep vacuum sufficiently high, a moderate amount of vacuum. I'm operating at 450, and keep the power very, very low, because if we have a high phaco energy getting delivered, we will keep cheese wiring the nucleus and prolapse one of the poles up. So slowly and steadily apply vacuum to slightly anteriorly to one of the poles of the nucleus, and once we are able to get one of the poles up and a little part of the heminucleus we are able to grab it, the rest of the surgery becomes very, very easy. So if stuck with a position like this where we have a formation of bowl, then just slowly and steadily apply vacuum to slightly more anteriorly than we would in a normal patient of cataract surgery, and this is how we can come out of a situation like this. So to summarize, different techniques can be used for soft cataract, and different techniques have been described in literature as well. What works in our hands here is either we prolapse one of the poles of the nucleus with hydrodissection in extremely soft cataracts with an adequate size of rhexis, removing the anterior sticky epinucleus so that we have access to the nucleus. Either we can make a shallow trench, or we can emulsify the whole nucleus together. And if we have a formation of a bowl, use lower power, reduce the phaco energy setting that we are using, and use a moderate amount of vacuum to go ahead with the procedure. Thank you. So I will move on to the next talk now, which is on posterior polar cataracts. And here we'll just go through a video of a posterior polar cataract. This is a patient who has high hypermetropia, nuclear sclerosis, and pterygium. So this is the right eye of the patient. The pterygium is not affecting or causing a significant astigmatism. We can see here that the aqueous depth is adequate even though the patient has high hypermetropia, and the astigmatism is about 0.5 diopters. This patient basically required visual rehabilitation, and he was not concerned